the benefit of estrogen really outweighs any potential minimal risk. Heart disease is the number one killer of women. It's not breast cancer, though that's what we're scared of. What about your benefit of reducing Alzheimer's, potentially 30 to 50%? What about the benefit of reducing heart attack and stroke? Around 30 to 50%. For those women who do have a higher risk of bone loss, estrogen is the one thing that actually can rebuild bone. You can use hormones safely.
Yeah.
Nothing is going to work like giving back what the body is missing.
Whether you're dealing with menopause-related symptoms or looking to improve your overall health, this podcast has something for everyone. Let's embark on this journey together to thrive through menopause and beyond. Welcome to Moving Through Menopause. I'm Phillipa, and this week joining me is Dr. Malaika Woods. She's certified with the American Board of Obstetrics and Gynecology, and she's also a functional medicine practitioner with a certificate in bioidentical hormones. So she's very well qualified to have this conversation with us today, all about menopause. Thank you so much for joining me.
Thank you for having me, Phillipa. Really excited about the conversation today.
Oh, well, thank you. Thanks so much. You're a best-selling author, which is amazing, and you love to sing in your spare time. Did you know I too am a singer?
Oh, I didn't know that. That's awesome.
Maybe we should sing our way through the podcast. We could do harmonies and everything. So I'm really keen to unpick this question about hormones, female hormones. As far as I understand it, and please do correct me at any time if I am wrong, our female hormones start to decline in our 40s, and that for a period of time, our hormonal levels are fluctuating wildly, which can be one of the reasons why we get perimenopausal symptoms. But then we transition through onward into postmenopause. And, I've got a graph where the hormones continue to do this on this trajectory downwards. And so, would you mind going through a little bit about including some of the measurements that we might expect to see, all about this hormonal conundrum, please?
Absolutely. So you're right. Hormone levels do start to decline in their 40s, and some of them even may start shifting in the late 30s. And the main hormones that we typically talk about are estrogen, progesterone, and testosterone. And with each of those hormones, when they're on their decline, there are different symptoms that can be associated with it. As far as kind of choosing a particular number, it is a little bit hard, Philippa, because the ranges are quite wide. And I also want to just kind of remind you that even month to month, those hormone levels can shift quite a bit. So our terminology in gynecology is let's relate it to the period because the hormone levels kind of shift in relationship to that. So if we take a woman who has a normal 28-day cycle, which not a lot of people have 28-day, but we use that as an example, technically 21 to 35-day cycle is considered normal. That's another just little tidbit there. But cycle day 1 is the day the period starts, and that's when the hormonal levels are at their lowest. At day 14, that is when ovulation hits, and that's when the hormone levels are at their highest. And so for a premenopausal woman or a woman of reproductive age, those hormone levels, again, they could range anywhere from, say, let's take estrogen, for example. It may be down in the 30s, and it could get up to 400 in the middle of the cycle.
Okay.
And then cycle days, say 15 down to 28, the hormone levels are declining again. So even day to day, month to month, probably hour by hour, those hormone levels do decline. And so or they shift, I should say it that way, sorry. And so one of the things when you're working with perimenopausal women, menopausal women, that I say all the time, Philippa, is that the blood level or the lab tells part of the story, but the patient and her symptoms tell part of the story. So you really have to use those two bits of information together. You're not treating just based on the numbers.
Yeah, no, I think certainly over here in the UK, menopause is a diagnosis, or perimenopause is a diagnosis that is made based on symptoms alone. And that we wouldn't be tested, our blood work wouldn't be done unless it was early on, if this was premature. and we were too young to be experiencing these symptoms, then we might get a blood test. But I'm really interested to understand what is optimum for a woman to be healthy, because that's the thing that I'm particularly keen to deliver for women, this healthy future, whether we're pre, peri, or post menopause. We want to be healthy. But the thing that we know is estrogen plays this pivotal role in bone health, in sarcopenia, muscle loss. And so, as a physiotherapist, this is something that I'm really concerned that women can preserve their function by hanging on to the muscle mass and by having healthy bones. And so, what are the sort of levels that you might be striving for in order to achieve that outcome? Because those things are asymptomatic. You don't necessarily feel those things.
Yeah, that's a great question. And back to your point about how the gynecologists in the UK manage hormones, it's
Mm.
actually similar here in the US for what I call the traditional gynecologist. Now, myself, I'm a non traditional because I'm a bioidentical hormone specialist and functional medicine specialist. So I like to look at numbers, but I also recognize that those numbers fluctuate. The best way for me to sort of equate it to some data, Philip, there's some studies that show estrogen levels around 60 or better is when you start to really see some of those other benefits of estrogen. So we first think about the symptom relief of estrogen. And so certainly if you're having hot flashes, night sweats, vaginal dryness, getting some estrogen on board will alleviate those symptoms. And typically, again, even in the bioidentical hormone world, part of the way that we judge how much estrogen we need is how much does it take to get rid of the symptoms. And then we sort of look at the lab as a correlate to say, okay, well, your lab levels, and let me say this as well, for a woman who is on the end stage of perimenopause or all the way through menopause, which technically menopause is a year without a period if you still have your
Mm.
uterus, those women may have estrogen levels that are undetectable. So you really,
Ooh.
by the end, there's nothing. Okay. And so, in one way, to go from nothing to something, you could feel great to go from an estradiol of less than 5 to 25. And you may come back and go, I feel amazing. The hot flashes, night sweats, vaginal dryness is gone. And so that's a good thing. And so I don't always judge it based on the number. But again, some data does show estradiol level 60 or greater. That's when you can see about 30% reduction in osteoporosis. You see about a 30% reduction even in the rates of colon cancer. Some
Mm.
studies and the number of the estradiol, the value is not necessarily related to all the studies. The studies actually just look at women on hormone replacement versus not. That's sort of a lot of
Mm.
the broader studies. There's one called the Nurses Health Study that's been a longitudinal study over decades. It's, I believe, over 150,000 women who've been followed,
Mm.
and they put them in categories of hormone replacement user or not. And the women who are hormone replacement users, they show the reduction in colon cancer, osteoporosis, reduction in Alzheimer's, 30 to 50% reduction in cardiovascular disease. So
Yeah.
the way we judge positive outcome is actually just user or not. It's really not the lab value in most cases.
Oh, I'm with you. Okay. So it was sufficient that they had the estrogen on board, is what you're saying.
Yeah,
That
that's
was
sort of
sufficient.
the delineating factor in a lot of the
Mm.
studies. There's just a few that will show the actual number, and in some individual studies at 60 or higher has also been shown with a, higher rate of seeing some of those preventive things with
Mm.
estradiol.
Okay, so we know that there's been a lot of chatter about hormones and the risk of breast cancer. And recently in the UK, we've just had the new NICE guidelines published on the diagnosis and management of menopause. And, they are quite clear that the study that was done, you tell me all about it because you know this better than
Yeah.
I
The
do.
Women's Health Initiative is that big study. It came out in 2002. Very vivid in my mind because I'm an OB-GYN, but also I was a resident at that
Oh,
time. And so
oh, okay.
it's something that we definitely dove a lot into. So the Women's Health Initiative was the largest funded study comparing Premarin and Prempro. Premarin is synthetic estrogen. The name Premarin comes from pregnant mare's urine. That's how it was
Mm.
initially brought about. And it's a mix of a lot of different synthetic estrogens. So there was a group of women on that, and the other group of women was on Prim Pro, which is that synthetic estrogen along with a synthetic progestin called medroxyprogesterone acetate. I
Oh.
believe it ended up being like a $1 billion study, largest ever. But there was a lot of problems with it, unfortunately, Philippa.
Mm.
And the subsequent 20 plus years to now, we've had a lot of issues as far as people understanding hormones, the risk of hormones, et cetera. Let me say that before they finished the study, they stopped it early. And the big headline was they stopped it because of an increased risk of breast cancer, heart attack, and stroke. They saw that in the group of women who were taking the Prim Pro. So it was a synthetic progestin along with the other. But there were
Mm.
some big flaws. So, first of all, the increased risk was not statistically significant. So they should have, probably waited it out to really figure
Ah.
out what the difference was. That's number one. Number two, the population of these women was problematic compared to what we do in the real world. So the average age of these women in this study was like 62. Whereas, we very rarely start a woman at the age of 62 on hormones. We usually start them in their 40s, like we said, when they become perimenopausal and heading into menopause. So the reason why that's problematic is because there were probably a significant amount of women who already had some sort of cardiovascular disease. They already had,
Mm.
many years potential risk of other issues. So that was another problem in the study. And then they've sort of gone back and rehashed, backtracked to where we are, sort of fast forward to, 2024. We have an understanding that even in that study, the estrogen only group did not have a higher rate of heart
Mm.
attack, stroke, or cancer, which seems counterintuitive because we've kind of been told, for a few decades that estrogen causes cancer. The other thing that we found, it was the synthetic progestin group that was problematic, but we
Mm.
also saw some of the benefits as well. So we did confirm the lower rate of colon cancer, the lower rate of osteoporosis. But
Mm.
you can imagine for 20 plus years and a couple of decades of women, they've missed out on the opportunity to have hormone replacement. And so, we're just starting to sort of tease through, and the pendulum is sort of swinging back. Philippa, for yourself, or I don't know if you've read this book, or maybe some of your listeners who like to dig a little bit deeper into this,
Mm.
there's a book that was published a few years ago called Estrogen Matters by
Oh.
Avram Blooming.
Mhm.
And I believe he's a cancer specialist, medical doctor. He started exploring the safety of estrogen because his wife was going through menopause. So he was trying to figure out, should we do this or should we not? What is the real cancer risk? And
Mm.
he came to the conclusion that you can, and I have the book somewhere around here. I usually will read the subtitle, but basically he says that you can use estrogen, and the subtitle is not only can you use estrogen safely, but it'll probably prevent heart disease, osteoporosis, and all these other things that we've mentioned.
Mm.
So the benefit of estrogen really outweighs any potential minimal risk. And I think that's been well established
Mm.
now. But the damage, sort of psychologically, to society from the
Mm.
Women's Health Initiative is really hard to unravel.
Yeah, yeah, yeah. Okay, well, thank you for, going over that, what is undoubtedly old ground for you, I'm sure, but I think necessary. So, what I want is to fix this menopause thing. I absolutely want to fix it. And, from my own personal perspective, hormone replacement therapy is a piece of this puzzle. And so the women that seek your assistance, is it always something that you would be treating women with, or are there women where that might not be the case?
Yeah, not every woman that I see does hormone replacement, though most of them do, I will say that. But I love what you're saying about the idea that it's a piece to the puzzle. And I definitely agree with you there. And that's really where the functional medicine side comes
Mm.
in, because functional medicine is about root causes and natural solutions. And
Mm.
so what sets me apart is that I'm not just a hormone clinic either. We're not just
Mm.
pushing hormones and do nothing else. So I love your focus on movement, which I think is so important. And we talk about a lot of pillars that women need to have in place as far as their health is concerned to really transition most optimally through menopause, or to quote unquote fix it, as we say. We kind of use that a little bit tongue in cheek, right?
Yeah.
But sleep is important.
Mm.
Stress, dealing with that is important. Your nutrition is important. Moving your body and building muscle is important. I heard someone say that muscle mass is the currency of aging. So, all
Mm.
of those things need to be lined up, as well as your hormones. And what I find in some instances, if you have those other pillars in place, when I think about those pillars, I kind of think about, just say the woman is sitting in a hammock and the pillars are holding the hammock and holding the woman off the ground, right? And so sometimes they come to me and all the pillars are low. And so they're just down on the ground.
Okay.
Nutrition's out of order, sleep, stress, everything. And we start working on all these pillars. And in some cases, a woman may say, I don't know if I still need these hormones anymore. Let me take that, out of the equation. And if the other pillars are high, then we may do well, not being on hormones. But if all of the other pillars are down and you don't have nutrition, sleep, stress, movement dialed in, you're going to more likely need the hormones. And let me say this too, Philippa, which is different now than what we had said during the Women's Health Initiative era. I'll say it that
Mm.
way.
Mm.
During that era, the advice was use the lowest amount of hormones
Mm.
for the shortest amount of time possible to alleviate the symptoms of menopause. The error in that is that we've had decades of data before the Women's Health Initiative, and now we've had decades of data after the Women's Health Initiative about all of these very important preventive benefits of hormones. And so, if a woman is focused on, I just want to take a little bit for the shortest amount of time to alleviate hot flashes and night sweats, well, what about your benefit of reducing Alzheimer's, potentially 30 to 50%? What
Mm.
about the benefit of reducing heart attack and stroke? Again, around 30 to 50%. I'm giving a wide range because it depends on the data. But I want to remind your listeners, Philippa, that heart disease is the number one killer of women. It's not breast cancer, though that's what we're scared of. I believe the heart disease risk, I'm going to summarize it, in the US is about 200K a year. Breast cancer is about 40K a year. So it's about 8 times as many people die of heart disease than they do of breast cancer. I may not have the numbers exact, but that's the rough estimate.
Mm.
So again, we have to think about all the benefits. And one hormone that I think a lot of women ignore, Philippa, and a lot of the traditional gynecologists don't pay attention to, is actually testosterone. So,
Mm.
the Women's Health Initiative was just estrogen and progestin, but testosterone has a lot of really amazing benefits, and it is important for women as well. So,
Mm.
not only sexual benefit, which is like helping with libido and helping to enhance orgasm, because for a lot of women, those things also tend to get lower, but the non-sexual benefits of testosterone, like energy, mental clarity, building muscle mass, back to muscle over
Mm.
time,
Mm.
so that your
Mm.
body can burn fat more efficiently. So it's definitely a dial that you turn in your favor in so many different areas. Testosterone is one that gets ignored a lot.
Yeah, no, that is interesting, and certainly it was in the guidance, but it generally comes under that heading of sexual dysfunction, and not the necessarily the added benefits of having
Mhm.
that in your, replaced. So can we just unpick this a little bit? Natural approaches to managing menopause. We hear about different supplements that people can take. I'm preach movement as medicine. There's no doubt about that. So is it possible? Is it really possible to have optimal hormone levels that give us those health benefits without hormone replacement therapy?
I don't believe it is possible, Philippa, not in what I've seen or studied to date. A lot of the natural things that we talk about that can help menopause, it's really about trying to alleviate the symptoms of menopause, hot
Mm,
flashes, night
okay.
sweats, etc. It's not about producing more estrogen necessarily. And
Yeah.
so there's really no way to get around probably using hormones if that is your goal. to really get to optimal levels, to get the benefit of muscle. And again, testosterone plays a huge role
Mm,
in muscle mass as well. So there's really no way to get around it. And really, I think the message that is hopefully breaking through right now is that you can use hormones safely. There's
mm,
no reason to fear it, but we've been living in fear of hormones, over the
mm.
last couple of decades, which has been the big issue.
Yeah. So, well, thank you for clarifying that for me. I mean, I'm just going to say phytoestrogens, the plant estrogens. Could we ever eat enough of those to make a difference? Could we?
I have not read any studies about, kind of does
Okay.
how much does a phytoestrogen really raise your estrogen levels? I'm not sure about that. I think that's a great thing to think about. But again, I just kind of go back to the idea that, anything that you can do. And again, we talk about complementary, comprehensive approach. I really think that is important. But I
Mm,
think the hormones themselves are a really critical piece, and, people define natural differently, granted.
mm.
And the way I say it is the most natural thing you can do is just give the body back what it's missing. And let me say this too, Philippa. I do
Mm,
make the distinction of bioidentical hormones.
mm,
I think that's important too. And not every gynecologist looks at that the same. The bioidentical has the same chemical structure as the hormone that your body naturally produces. And I think that makes a difference also. Again, there are more gynecologists, even the traditional world, that are giving more bioidentical versus synthetic. But I think that is my natural approach, is to look at the
mm.
bioidentical hormone versus a synthetic alternative.
Yeah, yeah, no, thank you for making that distinction because in actual fact, we call those body identical hormones
Okay,
over
yes.
here. So,
Yes.
but that is the same thing. We are talking
Mhm.
about the same thing. So yeah, derived from natural sources to correspond. What did you say? Correspond chemically.
Yeah, let me clarify, because
Mm,
bioidentical, our term here in the US is it has the same chemical structure, but I do also clarify, like, it doesn't
mm.
mean it was from the earth. So it might have
Okay.
been produced in a lab, okay?
Yeah,
So I do want to clarify that.
yeah,
Sometimes it could be
okay.
like yam derived or something like that, or it may
Mm,
just be, created in the lab, but that chemical structure identity is really important. And let me give you an example of that. Let's take progestins, which is what was
mm,
studied in the Women's Health Initiative. That's synthetic, and technically it should be called a progestin, medroxyprogesterone acetate, versus bioidentical progesterone. And so, bioidentical progesterone, which I call my secret weapon hormone, by the way, it has a natural sedative effect. How many women are having
oh,
trouble
yeah.
sleeping during this age? Right? It has a natural calming effect. So, how many women are more stressed, more anxious, getting more prescriptions for antidepressants,
Mm,
anti-anxiety
mm,
medications? Some people need that, but some women need their progesterone optimized. If we take a look at medroxyprogesterone acetate, it can have the potential opposite effect. And I'll give you some examples, and it's not, an exact correlation, but the Depo-Provera birth control shot, for example, it is
mm,
medroxyprogesterone acetate. Granted, it is a large concentration of it, but that particular medication has a potential to lower your mood. And there used to be a label in there: if you had significant depression, you
mm.
shouldn't take it. The medroxyprogesterone acetate has a link to the risk of breast cancer, whereas you see in progesterone, the bioidentical, it has been shown to be apoptotic or can kill off potentially breast cancer cells. So
Oh,
again, they're not the same. And so it's
mm,
important, the bioidentical hormone specialists such as myself, we make that distinction. The traditional gynecologists are starting to kind of shift over in that way. So there's
mm,
a lot to unravel. So I can
mm,
certainly understand why people are just unclear. So I think it's good to talk with a specialist, in your area,
mm,
to get
mm.
more clarification on it for what's right for you.
Yes, yeah. I mean, the individual approaches are important, undoubtedly, but I come back to the idea that there is an optimal level. So that said, if 25% of women are going to be fast bone lose, we don't know who those women are currently. Why is that happening? Is that something to do with the genetic propensity to have less estrogen than the average person, or is it something else? What's driving that?
I'm not sure if we know exactly why that is, but here is what's neat about estrogen for those
Mm,
women who do have a higher risk of bone loss. Of all the, fancy treatment options for osteopenia and osteoporosis, estrogen is the one thing that actually can rebuild bone.
mm.
All those other fancy treatments that also have a lot of significant side effects
Side effects.
potentially,
Mm.
they stop further bone loss. Estrogen can rebuild bone. So it just kind of goes back to what are the best options? Oftentimes it's just what is your body missing?
Yeah, yeah. Okay, so we come to see you, and we're all on board with all these other healthy things that stop us from dying from lots of other things. Actually, so they're good to do anyway. But as part of our prescription, we're happy to go along with hormone replacement therapy. And so, is that something where you're talking about different levels for different women?
Yeah, so it definitely depends on sort of age range. And so
Oh, okay.
perimenopause, again, we start with the definition of menopause, a year without a period. If you have a uterus, the average age of menopause is 51. But a lot of women will start having symptoms in their 40s. And so hormone levels for women who are perimenopausal, perimenopause is also kind of said like no man's land because you could have really high levels, you could have low levels. It
Mm,
can fluctuate, your periods get irregular. And so the approach that I typically take there, Philippa, is also the sequencing of the hormones. And this is where women
mm,
sort of get into sometimes complications with their hormone replacement. So, really, the last hormone that you add in a perimenopausal woman is estrogen because estrogen
oh,
can fluctuate so much.
oh, yeah,
And
yeah, yeah.
progesterone is chemically, structurally similar enough that it can often alleviate some of the symptoms that we typically attribute to lack of estrogen. So you can see relief of potentially hot flashes and night sweats with progesterone. And studies also show that you can alleviate those symptoms with testosterone. And so
Mm,
estrogen is last. The reason why is because we also worry about the relative ratios of estrogen versus progesterone. Estrogen is always higher than progesterone. But when women
mm.
start going through perimenopause, progesterone declines faster and
Oh,
so you get, in
a
effect,
big yeah,
estrogen
yeah.
dominance. And
Oh,
so
that
you
makes
don't
sense.
wanna overshoot and give too much estrogen on top of
Mm,
estrogen dominance, even though you have symptoms of lack of estrogen. So it's a little bit, more complicated there. So the way we alleviate that estrogen dominance is we bring up the progesterone. So that's another way that we kinda tackle that problem.
yeah. Oh, well, thank you so much for putting up with my daft questions.
No, I
Bec
love those answers. And it's just, with the actual lab value, it is woman to woman, and it's
Yeah,
a
yeah.
combination of the lab value and sort of how they're feeling. But I
Mm,
will say that women who are in menopause full blown, typically they have no estrogen. Once we
mm,
start treating, common ranges I see are anywhere from 30 to 100. That's kind of what I
mm,
typically see in my group of women. And I'm not treating to a number. That's just the numbers that fall
mm.
out. And they're also telling me I'm feeling good as far as I'm not
Yeah,
having the hot
yeah,
flashes
yeah.
and the night sweats anymore.
Yeah, at that level.
Yeah.
That's interesting because I'll tell you that I was one of that generation of women who heard on the grapevine that HRT gave you breast cancer, and I wasn't interested in having that. So I spent perimenopause having a terrible time of it. It was a bit annoying, really, to be honest, because I was a bit of a health freak. So it should never have happened to me, but I was having a terrible time. And the thing that I struggled with was actually insomnia. And so it sounds like a bit of that progesterone might have been
Mhm.
just the thing.
Yes, it probably would have been amazing for you.
Yeah. Oh, dang it. Anyway, I'm now well and truly on the other side. Post menopause is where I'm sitting now. So my recipe includes estrogen and it includes progesterone, as you
Yes.
say,
Yes.
the bioidentical or body identical versions of those hormones. Do you test women in your care? When they get to my stage of life, would it be an annual review, or where would you go with that?
Yeah, so I like to follow women long term. And when I first start working with a woman, and they come in to see me starting in the 40s, some women are in their 50s, some women are even in their early 60s when I see them for the first time. So early on in our management, I like to look at labs probably every 3 to 4 months because we may be
Okay.
adjusting. So I kind of
Mm.
want to see how the labs look in comparison to how they're feeling. And once we get on a stable dose, I like to look at labs minimum twice a year.
Oh, okay. So just to inform the discussion really around what,
Yes.
how they're feeling and what's happening.
Mhm.
I mean, and I think this is the difference between personalized medicine that you might be paying for versus what we have here provided in our wonderful National Health Service, where obviously the doctors are overburdened with the work that they have to do. But for us to get that personalized care, I'm afraid it does mean parting with our hard earned cash. Is that the same with you over there?
Yeah, definitely for my practice and the physicians that I coach as well. We call it
Mm,
an independent or cash-based practice. But
mm,
I like to give this analogy, Philippa. I look at your health insurance kind of like car insurance. So in the US,
mm,
car insurance, pays for if your windshield breaks or you get into a wreck. Your health insurance is going to pay if you break a bone or if you have a major illness, but your car insurance doesn't pay for tune-ups and it doesn't pay for gas. And so your health insurance is not going to really pay for, I'm trying to optimize my health. You
yeah.
really want to be interested in making an investment in yourself. And, I kind of challenge people to say, how much do you invest in on a regular basis on all the other things that you're interested in? And I could go down the list, hair, nails, makeup, all
Mm,
kinds of stuff, right? So I kind of, either people have an interest in investing in their health or they don't. And if they don't, then they just go to what's provided. But if they want to take a deeper dive and have something more personalized, then they will invest in themselves. And I think that, the women maybe that you've talked to, Philippa, definitely the women that I see, 99 times out of 100, they're going to tell you it was worth the investment.
yeah. Yeah. You're never going to regret feeling healthy, are you? I mean,
Right.
no.
And it could literally save your life. Like, we really have talked about some of the
Mm,
preventive benefits of hormone replacement. So
mm.
it's priceless, really.
Oh, it really is. Yeah, definitely. So, as a functional medicine practitioner, are you also treating the gut issues, treating all these other sort of that really do come along with menopause?
Yeah, I definitely take a look at the gut, and I do that almost across the board. So,
Mm,
women who come to see me for hormonal issues, we have a discussion about the importance of gut health overall, the issue with
mm,
inflammation. We
mm,
talk about, and in some cases, we look at specialty cortisol testing to see how the adrenal glands are working, thyroid
mm,
optimization.
yeah,
So,
yeah,
when I
yeah.
say comprehensive, we really try to take a look at it all.
And that's the thing, because these things are so intertwined with one another. And although I think, I'm kind of getting the feeling that the way to optimize our female hormones is with hormone replacement therapy, and everything else is icing on the cake and supporting our well-being in the broadest sense, but it's not really going to be changing the numbers that you would see in the blood works.
That is true to my understanding. I have not,
Yeah.
nothing is gonna work, like giving back what the body is missing.
No, no. Okay. Well, thank you so much for helping me to understand today more about the female hormones and that part of menopause management that I was really struggling to get my head around. I feel like I'm clear on it now, and I think the listeners will be too. So I really want to thank you so much for coming and having this conversation today. Please tell the listeners where we can find you and how you might be able to help them.
Absolutely. So I have a free Facebook community called The Natural Hormone Fix. And so
Okay.
I go live almost every Tuesday night. And
Oh,
so I talk about all things hormones, functional medicine, kind of blending those things together. For people who need one on one help, I can help people who live in the US states of Kansas, Missouri, and California at this time. And so, again, we can connect via the Facebook group. My website is drwoodswellness.com.
Thank you. Thanks for that. It's been wonderful to meet with you. I'm sorry we never got to sing a duet.
Oh, I know. Maybe next time.
Maybe next time. Well, take care. Have a wonderful rest of your day. And thank you so much for your time today.
Thank you for having me.